Good evening, everyone. A very warm welcome to one and all. I'm Dr. Komal, and I am joining you all from the beautiful city of grapes, Nasik. And it is my privilege to moderate today's webinar by CCI, that is Nipah virus infection in India. Where do we stand? First of all, let me thank the entire CCI team, especially Dr. Krishna, Dr. Narayana, Dr. Maske, Dr. Dubey, Dr. Chilamchiti, and all of those who's been working tirelessly to make CCI one of the best academic platform for pulmonologists. Previously, Thursdays used to be very boring, like routine weekdays. But now, we all pulmonologists wait for Thursday evening because here we get the chance to meet, greet, and learn from our favorite pulmonologists across the India through the screen. And today's webinar is all the more important because it's the real life scenario. We all know that recently in January 2026, we had two proven cases of Nipah virus infection in West Bengal. These two were are healthcare workers, and luckily, fortunately, the good news is the main nurse, the healthcare workers, who also suffered from encephalitis and ARDS, is now absolutely disease-free. He is RT-PCR negative, and he's been discharged also. The female nurse is also recovering well, and none of the contacts of these patients are positive. Isn't it a good news? Why this happened? Because there were high suspicions of these cases, timely and prompt diagnosis and treatment, strict infection control protocols, and of course, a huge support from the government. The point is that however the mortality, however deadly the infection is, if we know the details, if we can still fight it very well. And for that only, we have today's webinar. And I'm so privileged that I have a wonderful group of panelists here, not just across the country, but across the fraternity as well. We have infectious disease specialists, we have microbiologists, we have specialists from medicine, community medicine, and our very own pulmonologist. Isn't it great? So let us begin. So our first panelist Sir has more than 100 publications on his name. He has multiple professional membership, and he has written 3 chapters in book and 1 book as associate editor. He has multiple awards and honors. Very welcome, sir.
Thank you.
Next, we have Dr. Gagan Gunjan, sir. Sir is associate professor and in charge, Central Emergency Medicine, RIMS Ranchi. He is also affiliated with Rajendra Institute of Medical Science, Ranchi. He is empaneled course counselor to IGNOU Delhi and ex-resident of AIIMS Patna. Sir is also joint secretary and scientific committee member to API Jharkhand. And he has multiple awards, honors, and publications, especially API Youth Talent Award by East Zone API and Health Icons of Jharkhand by Times of India Group in 2024. A warm welcome to you too, sir.
Thank you. Thank you so much.
Our next panelist is Dr. Uma Maheshwari ma'am. She is senior consultant microbiologist at Yashoda Hospitals, Hyderabad. She has more than 13 plus years of experience post-MD. She's expertising in clinical microbiology, infectious disease serology, infection prevention, antimicrobial stewardship, and molecular diagnosis. Ma'am is certified internal auditor and has been awarded Ratna Award in 2022. We do have infectious disease specialist also with us. That is Dr. Venkat Ramesh, who's also going to deliver the talk today. Sir is consultant in infectious diseases, Apollo Hospital, Hyderabad, and is also assistant professor Apollo Institute of Medical Sciences and Research, Hyderabad. I can read 1, 2, 3, 4, 11 degrees attached to his name here. It's quite a lot to say, but it's great to have you with us, sir. Welcome.
Thank you.
And finally, we have our very own pulmonologist, Dr. K. Vishnu Chaitanya. He's the assistant professor at Gayatri Vidya Parishad Institute of Healthcare and Medical Technology. He's also cleared successfully EDARM, that is European Diplomat of Adult Respiratory Medicine from ERS Education, and DNB Respiratory Medicine exam by NB. He's completed a foundation course in peeling and palliative medicine as well. I welcome you, Dr. Vishnu. So let us begin with the first talk today by Dr. Venkat Ramesh.
Hello. I would like to thank Chess Council of India for having me here today, having invited me today. It's really an honor and a privilege for me to be here. And thank you to Dr. Komal Shah for the kind introduction. Today we will be discussing a very important topic, that is the Nipah virus and where do we stand. The topic is of extreme importance because we have recently had 2 cases in West Bengal, and we need to be aware of this virus. My name is Dr. Venkat Ramesh. I'm an infectious disease physician at Apollo Hospitals, Hyderabad. So we first need to understand why the Nipah virus matters. It is possible that these 2 cases are the only cases that we will have, and then this outbreak will not be there in the news. At least we hope that is the case, and we will be lucky if we don't see any more outbreaks. But we need to be aware of this virus, that it exists in India. Why? Because it has a very high fatality rate. The mortality rate is extremely high, from 21% to 100% across different regions. Global mortality rate of 80.1% was reported in the decade from 2014 to 2023. There was a meta-analysis done by S. Vasudevan et al. He looked at 2,736 patients and found a very high mortality rate. And in the data, India had a high mortality rate of 82.7%. So although the incidence is low, the high fatality rate makes it imperative that we are aware of the Nipah virus. There is additionally rapid neurological and respiratory deterioration. We will discuss that in the upcoming 20-25 minutes. No vaccine or proven antiviral. And we are all healthcare workers, and there is a disproportionate healthcare worker risk. I mean, compared to any other disease that we see, like HIV, tuberculosis, disproportionately healthcare workers are impacted by Nipah virus. And most importantly, it is a public health crisis if it spreads into the community. The hospitals are impacted, and it can turn into a very nasty situation if it is uncontrolled. So whatever happens in the current outbreak, and hopefully it just dies down by itself, we need to be aware of Nipah virus as clinicians, healthcare workers. It is very important. So what we will try and discuss in this webinar is 4 things. Okay, so the 4 topics for discussion. First is just a little bit of analysis on India-specific outbreak patterns, what has happened in Kerala, West Bengal, and what does this tell us about spillover, transmission, and containment. That is one. And then I will present a little bit on the clinical features of Nipah virus and how to identify a patient of Nipah virus, when do we suspect it. So one major disclaimer is I'm a practicing ID physician in Hyderabad, Telangana, and I haven't seen or encountered Nipah virus in the clinical setting. So that disclaimer is there. Most of what I'm going to be discussing is with knowledge gained from other colleagues, in case discussions, clinical meetings, and so on. So that needs to be, we need to look at it in the right background. So what I'm going to try and tell the audience is, no matter where in India you're practicing, you need to be aware of how to identify Nipah. Okay, patient comes to the casualty with certain symptoms. We need to be able to identify Nipah, and it has a lot of implications. So how do we go about things? That is something we'll discuss. What are the early clinical red flags? And most importantly, it is infection control and hospital preparedness. So I had a discussion with a colleague and a good friend of mine yesterday. Uh, the Professor Arvind Regu Kumar sir is the head of Department of Infectious Diseases at Government Medical College Trivandrum, and he has seen a lot of cases of Nipah. And I asked sir, what if you could give one message to the audience, because you've treated Nipah at the bedside, you know what is this virus, what would that message be? And he said the most important thing is infection prevention and control. So IPC is of paramount importance. And I think if there's one take home message from all this discussion, it should be on infection prevention and control. That will be discussed in quite detail in my session as well as in the upcoming panel discussion. And then the road ahead. How do we strengthen surveillance, diagnostics, and outbreak containment for future Nipah preparedness in India? That's something that will also be discussed. So, India has experienced multiple Nipah virus outbreaks, with three major incidents documented in 2001, 2007, and 2018, primarily in West Bengal and Kerala states. And I have highlighted that with the star, the blue star. The 2018 Kerala outbreak was particularly significant, with 18 laboratory confirmed cases and a devastating 88.8% case fatality rate. The outbreak was characterized by person to person transmission, primarily spreading through hospital settings, with the index case likely infected by fruit bats. So now recently we have two confirmed cases in West Bengal, and thankfully, out of the 196 contacts that have been traced, they are asymptomatic, they are tested negative. So hopefully, by God's grace, it will only be restricted to these two cases. So the typical pattern that we see is there is a spillover from the fruit bats into the index case, and that is followed by healthcare amplification. Okay. So before going to the clinical features, let's try to understand what are the lessons that we have learned so far, right? The first and most important is faster syndromic surveillance over time. So we need to be able to identify Nipah virus at the bedside, and that is called syndromic surveillance. That has really improved after the 2018 outbreak. Early isolation of encephalitis cases, aggressive contact tracing, clear risk communication with the public. All of these are things that we have learned from Kerala. So much so that the Kerala government has done an excellent job, and it now tests all patients with acute encephalitis syndrome for Nipah virus. That is something that we need to appreciate. So there was a case admitted in a private hospital in Kerala, and patient had acute encephalitis syndrome, and patient expired. And when the case came up for mortality, because the government goes through all the data of acute encephalitis syndrome cases, they had found that the Nipah virus wasn't tested, and MBBS doctor looked at it, and thankfully the patient serum was there, that was tested for Nipah. It was positive, and the contact tracing could be done, and further cases could be averted. So that is something that the wheels are in motion in Kerala. All acute encephalitis syndrome, they are tested for Nipah, and if positive, of course, they will be isolated. Aggressive contact tracing will be done, and there will be a clear risk communication with the public. Those kind of things are in place. So one thing is index case recognition sometimes remains delayed. That is something I think clinicians need to be more aware. And going ahead to the core presentation, I would suggest that all of us read this excellent guideline for surveillance, diagnosis, treatment, prevention, and control of Nipah virus infection. This is prepared by Department of Health and Family Welfare, Government of Kerala. And I think all of what we are discussing is going to be based on their experience and their guidelines. See, this is a virus which is extremely rare in a sense. It's not seen. So only few states have, few places in the world have experienced, few countries have experienced: Malaysia, Singapore, Bangladesh, and India. And in India, again, Kerala has most experience. Second is West Bengal. So there are no randomized clinical trials to guide what should be the treatment protocol. It has such a high case fatality rate. You will probably not have any good RCT data. Most of it will be restricted to case reports and case series. So, we need to learn from people who have experience in dealing with this virus. And this is an excellent document where they've talked about the epidemiology, burden of disease, transmission, diagnosis, including clinical features, lab diagnosis, and management. So I would encourage all of you to read this in detail. So now we will just discuss what are the common patterns across the Indian outbreaks. So the first thing to remember is that the index cases often missed initially, and we as clinicians should be aware of that. Secondary cases are caregivers or healthcare workers. Respiratory involvement increases transmission risk. Delays lead to large contact lists and fear-driven disruption. So let's just try to understand for a minute what are the clinical features, what are the patterns across Indian outbreaks. So Nipah virus is transmitted from person to person, primarily through close contact with infectious respiratory secretions and body fluids. Transmission occurs most efficiently through direct contact, with the key risk factors include prolonged exposure of more than 48 hours, contact with body fluids, and interactions with symptomatic patients. Notably, spouses face the highest risk at 14%, compared to 1.3% for other family members and 0.9% for other contacts. The transmission risks increases with patients experiencing respiratory symptoms, particularly among the older patients. So, if patient has respiratory manifestations, they are at much higher risk of transmission. So these things need to be kept in mind. Okay. Now, Nipah is clinically missed for multiple reasons. One is the presentation is extremely non-specific. It can mimic meningoencephalitis, can mimic sepsis, severe pneumonia. We had our annual conference called SITSCON, and last year a case was presented where a patient came in with meningoencephalitis. And this patient, CSF biofire, that is the meningitis panel by film array, showed Streptococcus pneumoniae. But CSF gram stain was negative. There was no gram-positive diplococci. CSF culture was sterile. Blood cultures were sterile. But because of this biofire showing Streptococcus pneumoniae, the working diagnosis was pneumococcal meningitis. Patient then developed a severe pneumonia, ARDS, like a severe acute respiratory illness. So they thought it was pneumococcal meningitis, pneumococcal pneumonia, sepsis, and so on. But patient did not get better. Then retrospectively, not retrospectively, but then they thought, okay, patient is not improving. They tested for Nipah and Nipah was positive. So please remember that it can mimic meningoencephalitis, sepsis, severe pneumonia. Early imaging and CSF findings may be non-specific. In fact, if you look at the first outbreak in 1998 in Malaysia in pig farmers, they found that they first thought it was a Japanese encephalitis, but then they realized that it's happening a lot in adults. And imaging patterns are also not characteristic and so on. So that's how this Nipah was discovered. In fact, Nipah is named from the village in Malaysia. Confirmation often comes late. It's not so easy. See, none of our common, how we test for dengue, malaria, chikungunya, scrub typhus, enteric fever, all those things, or common, community acquired pneumonia, pneumococcus, H influenza. You cannot test like that for Nipah. So confirmation often comes late. Suspicion depends on clinical context, not tests alone. Just think of the clinician who first diagnosed the index case of Nipah in Kerala, whether it's the 2018 or 2021. they have to have a very, very strong index of suspicion. So that needs to be kept in mind. Now, what are the early clinical features of Nipah? It can present as an acute encephalitis syndrome with high mortality, okay? Presenting with a range of clinical features from a mild respiratory illness to a fatal neurological complication. See, the clinical data uh, is not very clear as to what percentage present exactly in what manner, but there are three presentations that we need to remember. One is acute encephalitis syndrome. Second is severe acute respiratory illness or severe pneumonia, community-acquired pneumonia, severe acute respiratory illness, SARI, ARDS, that kind of presentation. And third thing is myocarditis. In critically ill patients, definitely myocarditis it has been reported. So there is a little bit of a variation. In Malaysia and Singapore, they had more of a neurological presentation or neurological features kind of predominated and overshadowed everything else. In Bangladesh and India, we see also respiratory features. Now, the problem with the respiratory symptoms is that there is a high transmission rate if patient has like ARDS, severe pneumonia kind of thing. So that needs to be kept in mind. So initial symptoms very non-specific: fever, headache, dizziness, vomiting, and then they will have either a acute encephalitis syndrome kind of presentation or uh, some kind of a severe pneumonia kind of illness. So distinctive neurological signs include myoclonus, areflexia, and autonomic disturbances. In fact, they say like segmental myoclonus is seen with Nipah. So seizures are reported in 30%, segmental myoclonus in 5%. Although in the recent Kerala outbreak, they reported much more myoclonus of 30%, seizures and only 5%. But anyway, that is a minor point. Please remember that acute encephalitis syndrome, severe pneumonia, these are the two characteristic features of Nipah virus. Especially if you have acute encephalitis syndrome with ARDS, please consider Nipah, especially in the correct epidemiological context. Okay. So early clinical red flags: acute febrile illness with rapidly progressive altered sensorium, new onset seizures or brainstem signs, unexplained respiratory distress, and more importantly is the epidemiology: healthcare worker illness or clustering of cases. So maybe the index case could be a healthcare worker, or index case identified could be a healthcare worker with acute encephalitis and ARDS. So any patient with acute encephalitis syndrome with ARDS, please keep Nipah in the back of your mind. Okay, especially if there is a clustering of cases or it is a healthcare worker. I think that is the most important clinical feature wise take home point. Now, I told you the Nipah virus, two major hosts. The natural host is the infected fruit bat, and that through blood, urine, or saliva, through the palm sap, it will infect humans, or even through contaminated fruits, it can infect humans. And then there is a human to human transmission. Or in the first outbreak in 1998 in Malaysia and then in Singapore, you had it coming from pigs. It was first reported in pig farmers in Malaysia. So, and then through the pig farms, it came to humans. That is something to keep in mind. So the case fatality rate is about 40 to 75%. So these are the symptoms, as I told you, not very specific for anything, but you can remember it in two or three ways. One is acute encephalitis syndrome, especially with brainstem encephalitis, segmental myoclonus. Second is severe acute respiratory illness, severe community-acquired pneumonia, acute respiratory distress syndrome. Third is myocarditis in severe cases. Epidemiological clues that matter: contact with suspected or confirmed Nipah cases, exposure in healthcare settings, residence or travel to affected districts. Please take in all patients with acute encephalitis, please take a proper travel history. Take a history of any close contacts who have similar symptoms. So cluster of febrile encephalitis. There is a 24-hour rule, right? If you have a AES, acute encephalitis syndrome, plus epidemiological risk factors, first we need to, like, patient comes into the casualty with acute encephalitis and there is maybe a history of travel to Kerala or West Bengal, or there is he there is a history of close contacts being similarly affected. We need to isolate the patient first, notify public health authorities, and says test later, but in the sense that testing is done simultaneously, parallelly. But the major thing is first we need to isolate, we need to think about Nipah and testing. Few centers do it. Like let's say tomorrow there is a case in Telangana, we will have to send the samples to National Institute of Virology, Pune. Exposure prevention cannot wait for confirmation. So we need to act first because you need to prevent transmission, you need to halt the transmission. Infection prevention and control is of paramount importance. Actually, in suspected cases, just a triple ply mask will be enough. So when you go to examine any patient in the casualty, especially with AES or SARI, please wear at least a triple ply mask. Once the case is confirmed, we wear the PP, N95 and all, but that's not practical for all the cases to wear the N95. So at least a triple ply mask. That is what I would suggest. So this Kerala document has given excellent risk stratification of contacts into high risks and low risks. And any contact with body fluids, blood, urine, saliva of a confirmed case of Nipah, or a probable case who died without lab confirmation, or who has spent time in close proximity or in a closed space for more than or equal to 12 hours becomes a high risk. Low risk is touching, contact with clothes or linen or any item used. And the high risk patients, twice daily for 21 days, they will be contacted. And if they are symptomatic, they will be admitted in a designated isolation ward with ICU facility. If it is low risk, just a telephonic follow-up and immediate admission in, if there is fever. So coming to the last few slides, why healthcare workers are at risk? Because they obviously engage in close patient contact, aerosol generating procedures. Let's say we intubate a patient with SARI in the casualty. There is a major risk with aerosol generation, delayed suspicion and isolation, and sometimes in confirmed cases, there is fatigue and lapses in PPE adherence. Infection control priorities, this is the most important thing. And I think if you have to take home one point, please keep this in mind. Single room isolation for suspected cases, standard contact and droplet precautions, N95 mask during aerosol generating procedures, and strict donning and doffing supervision. Please remember, testing is not the first step. It's not so simple to just take the sample and send it. We need to ensure that infection prevention and control is in place. So what we typically do is, for any patient with acute encephalitis, if you're suspecting Nipah, you need to send 4 samples: blood, urine, nasopharyngeal swab or throat swab, and CSF if it is done. So these 4 samples have to be sent. RT-PCR is the gold standard. Serological tests can also be done, but it's not commonly used. And they say plaque reduction neutralization test requires biosafety level 4, so we don't do that. But RT-PCR, that's more than sufficient. Sample handling requires strict biosafety. Delay in diagnosis is still acceptable, but not delayed infection prevention and control. So you need to isolate the patient and prevent infection to spread. So looking ahead, we need to strengthen acute encephalitis syndrome surveillance. So ideally, in ideal situation, we need to be able to test for Nipah virus in AES cases, especially in the surrounding states, and ideally in all cases, real-time district level reporting, integration of human and animal health data, and early detection before hospital amplification. We also need faster access to high-level diagnostic facilities, clear sample transport pathways, mobile and regional laboratory capacity, and predefined outbreak response protocols. That's already in place in Kerala. And I think other states need to adopt that, and healthcare workers in other states need to be aware of all of these things. Especially, they need to be aware of what to do if there is a suspected case of Nipah. So I've told you about the clinical features, how to diagnose, how infection prevention and control is the mainstay, I would say. See, Nipah is rare, lethal, and unforgiving of delay. There is no specific treatment. Whatever antivirals, monoclonal antibodies are there, the major treatment is supportive, right? So we need to prevent further cases. Once you have, one case, you need to kind of ensure that is the last case. So we need to really cut down on further propagation of infection. Early suspicion and isolation saves lives. Hospitals are the critical battleground. And again, I keep saying, infection prevention and control is really where the battle is won. Preparedness determines containment. So, thank you again to Chess Council of India, and I will hand it over back to the panelists for the panel discussion for the moderator to go ahead. Dr. Komal Shah, thank you for Chess Council of India for giving me this opportunity. Thank you very much.
Thank you so much, Dr. Ramesh, for the excellent talk. And what I can understand, what if I to take from your talk, it is the first case has to be the last case. I really like that line. And I really like the way you actually spoke to the people who have been treating bedside these Nipah virus cases, and you gave us the real life panel discussion here. Going back to the two cases which happened in January 2026 at Bangladesh, in West Bengal. So this nurse, female nurse, she was traveling to Bangladesh border, and with that, she presented with fever complaints of fever and anaphylaxis. So, and these both nurses had done same duty on 20th December together. There is another theory that they both gave CPR to old dying had received CPR by these two nurses. And this gave the suspicion that this could be Nipah. So immediately the samples were sent, all 6 samples. They had sent blood, urine, and oropharyngeal swab. All the samples came positive for Nipah virus. So immediately they were started on antiviral treatment. They were started on ribavirin. They were also given favipiravir and remdesivir. And fortunately, both of them developed even encephalitis and ARDS. Both of them got intubated. They were on ventilator. But fortunately, this male nurse, he resolved completely. He was extubated, sent home in a complete hemodynamically stable condition, and RT-PCR was negative. The female nurse, she had to be tracheostomized. She is now off ventilator, off inotropes, but her GCS is 5/15, and she is still in the recovery phase. So this is a story of this recent Nipah virus infection in West Bengal. None of the contexts have been positive in this case. It is a very good take-home message for us. So let us start the panel. First question is to Dr. Gagan.
Ma'am, you are not audible. Please repeat.
1998, as Sir mentioned in his talk. The name also was given from the village.
Dr. Komal, you're not audible.
So, could you repeat was detected, how cluster of cases subsequently appeared in other part of Southeast Asia and South Asia. Now, am I audible now?
Yes, ma'am. Now you are audible.
Hello. Yeah, am I audible now?
Yes, ma'am. Now you're audible.
Okay, so where were we?
You are putting the first question, which can be repeated again.
Okay, so first question is for Dr. Gagan Gunjan, sir.
Yes,
So
ma'am.
Nipah virus was first recognized in 1998. And could you please briefly outline where it was first detected, how clusters of cases subsequently appeared in other parts of Southeast Asia and South Asia, and could you please summarize the pattern of outbreaks reported in India so far?
Yes, ma'am. We just now heard Dr. Ramesh. He very rightly said that Nipah virus disease is an emerging zoonotic infectious disease. That is, transmission is between the animals and human. So it belongs basically to the genus Nipah virus and family Paramyxoviridae. CDC identifies it as category C, bioterrorism agent, and WHO identifies it as biorisk hazard group 4 pathogen. Coming to its old history, Nipah virus was named after one of the affected Malaysian village that was Kampling Sungai Nipah. It mainly affects pigs and humans. It was that was identified in 1998, and it was then subsequently imported to Singapore via live pigs during March 1999, and that led to almost 11 cases with one death among the workers. Since its discovery, if you go back, then it has caused numerous outbreaks, resulting in almost 754 cases, mainly in the Southeast Asia region. Of these, 46% cases have been reported from Bangladesh, Malaysia has 36.5%, and India reports 13.5%, whereas Philippines report 2.5%, and Singapore has the lowest of 1.5%. If we look at the India, then initial NIV outbreaks, Nipah virus outbreaks were in humans reported from Siliguri probably in 2001. And then if we try to subsequently look at this, then what we have, in 2001, we had 66 cases, of which resulted 45 deaths, accounting for almost 68% case fatality rate. That was in Siliguri, West Bengal. Then it came back to then it came moved forward to 2007, where we had 5 cases in a Nadia district of West Bengal. In 2018, we have 19 cases from Kerala, that is Kozhikode and Malappuram. And again, 2019, it was Kerala, one case, 21, again, it was Kerala, 23, again, it was Kerala, and the place was same, Kozhikode. And latest was to 2025, that is 4 cases from Kerala, that is Palakkad and Malappuram. So far, we have this, and we have already heard recent 2 cases that have been reported from West Bengal, which you were all discussed about.
So excellently put, sir. So basically, what we understand is India has around 13% of rate, and most affected areas are West Bengal and Kerala.
Kerala,
Right?
yeah.
Only
It's
these two
almost,
regions we
case
have.
fatality rate ranging
Yeah.
from almost 40 to 75% in most of the cases between the global
Yes. So in
synergy.
India, we have seen only in these two regions so far.
Yeah.
We have not
Yes,
seen
ma'am.
the cases in any other regions. And plus, we have had cluster of cases like single one or two cases as well as outbreaks, both present in
Yeah.
India, if I'm
Yeah.
not wrong. So
Yes, ma'am.
yes. Okay. So with that, Dr. Venkat Ramesh, you also already mentioned in your presentation that it was first identified as Japanese encephalitis. We all know about it. So, what made scientists or what made the physicians think that this is not Japanese JE and something else? Like, can you please point towards the points?
Yeah, I think so. We can look at it in terms of three ways, right? Clinical, epidemiological, and lab wise. So, epidemiology wise, first thing we need to understand Japanese encephalitis occurs mostly in children. Nipah was occurring in adults, and completely epidemiology, it behaved differently. It was more restricted to pig farmers, close family contact. Now, why should a family, multiple people in the family get Japanese encephalitis? It is mosquito borne. Then again, seasonality. So Japanese encephalitis is quite common, at least in the tropical areas during the monsoon time. In the temperate areas, sometimes in summer and fall. So it wasn't fitting in that scenario also. So more adults being affected, pig farmers, something directly related to pigs, strong contact history, as well as adults being more affected. So all these things epidemiologically didn't fit. Now clinically, see there is some commonality. Both of them cause acute encephalitis syndrome. They can cause fever, headache, seizures, altered mental status. Yes, but Nipah produces a lot of brainstem encephalitis. So you will see patient having hypotonia, areflexia, even cervical cord involvement may be seen. They can have hypertension, tachycardia, those kind of autonomic dysfunction can be seen. Some cases they do have a relapsing encephalitis. And you have prominent respiratory symptoms. So it can just present like an ARDS kind of presentation that you don't see with Japanese encephalitis. Japanese encephalitis causes more of movement disorders. So that's one part. Then, so respiratory presentation, that would have given the clue to the physicians to go ahead with that it was something novel. And lastly, the testing. So Japanese encephalitis, CSF, and serum IgM would have been negative. Of course, lymphocytic pleocytosis would have been seen in both cases. MRI pattern would also have been different. So Japanese encephalitis involves the thalamus and basal ganglia. Nipah produces more of subcortical and deep white matter changes. And of course, they would have tested for J, it would have been negative, and then they would have identified a novel paramyxovirus. So that's how they kind of concluded it. And yeah.
So probably it was similar to JE, but with lot of differences that led to the discovery of this new virus. And I read somewhere that it is very much similar to the virus outbreak which happened in 1994 in Australia. And with that, they got the clue about the new Nipah virus.
Right.
This was discussed in that Singapore meeting where they had discussed about the Nipah. So that gave them the clue that they should look for something new rather than J. Okay. So my next question is for Dr. Uma Maheshwari ma'am. Could you please explain the basic virology of Nipah virus, including the genome structure and sequencing characteristics? And is it similar or different than how it is similar or different than other RNA viruses?
Yes, Dr. Komal. Basically, Nipah virus is pleomorphic. It can be spherical or filamentous virus, enveloped virus, negative sense RNA, single-stranded RNA, and the RNA is non-segmented RNA. So this is the major thing. It belongs to Nipah virus genus and Paramyxoviridae family. And the basic difference occurs is basically all Paramyxoviridae viruses, whatever are they use sialic acid receptors to bind to the host receptors. But basically Nipah virus, it uses nephrin B2, B3 receptors. With the help of these receptors, it binds to endothelial cells and neurons of the host cell. Because of this, it has more potential to cause this vasculitis and encephalitis, which because of this, they are more prone to cause severe multi-organ dysphagia. So this is the main thing. Other than that, what we can say is the G protein, which it is having, it lacks the hemagglutinin and neuraminidase receptors. This is one major difference which I see. And when compared to measles virus, which is a segmented RNA, this is a non-segmented RNA. When compared to Ebola virus, it belongs to Filoviridae family. This belongs to Paramyxoviridae family. These are the basic differences. And coming, one more basic thing is, it has a large genome, 18.2 kb. This is the main thing because of which case fatality rate is comparatively more compared to other RNA viruses. So this would be the major differences which I would see, and these are the similarities. I think these are the ones.
So the large genome leads to what? Like
it follows the basic rule of 6. It multiplies more mutations. So because of this, it progresses to high case fatality rate. This is the thing.
Okay, so there is more multiplication and more, yes, and that's why maybe the period is also very low, that even after infection, immediately patient presents with encephalitis and ARDS, maybe because of the genome size and the receptors that you mentioned. Yes. Okay, coming back to the next question, the question is to Dr. Animesh Jain, sir. So could you please elaborate on the transmission dynamics of Nipah virus? What is the primary reservoir? What is the secondary or intermittent host? And how is it transmitted from animal to human, human to human, human to healthcare workers? Can you please? We are actually blessed to have very much different faculties today. We have microbiologists, we have community medicine people. So we can cover all the aspects of this Nipah very well. And it is a very good thing to have you all here. To Animesh Jain, sir.
Thank you, Dr. Komal, and I also thank CCI for having me here. So, basically, see, I think I must thank Dr. Venkat that he had made a very good presentation initially and clarified a lot of things. But as we all know, and he has also said that the natural reservoir is still the fruit bats. And we've seen that in multiple outbreaks, including in Kerala. So that's the natural reservoir that is of the Pteropus genus. But intermediate host, interestingly, he talked about Nipah coming from the Malaysian village. So 98-99 outbreak, we saw that in Malaysian outbreak, pigs were the ones which were the major culprits as intermediate. And I don't think that is a much known fact. I was preparing and reading for this webinar, so I saw 2014 there was an outbreak in Philippines where even horses were the intermediate.
Yes.
And other than that, dogs, cats, all those like even domestic animals have been implicated. But these are the two things I wanted to bring: the pigs and the horses. And modes of transmission, you've already said bats to humans, animal to human, or human to human. So if you see Bangladesh and India, it is very well documented that we've had human to human transmission as well. But usually it is bat to human. And bat to human happens, as we have known, in the last couple of outbreaks in Kerala. The thing came to light that these fruit bats and also half-eaten fruits which have fallen and which have been eaten, these are the ones which are implicated. So infection can occur through any of these things. And one of the things which is very commonly implicated, what I want to suggest here is that what we call as raw date palm sap or the tadi or whatever something you can call. So this gets contaminated by the bad secretions. It could be urine, saliva, anything. And this, when consumed, can lead to this. So this is one thing. And the other thing is obviously the fruits, which can be half-eaten. And other than that, what also happens is animals. So I mentioned about the intermediate host. These help in amplifications and keeping the virus. So what happens is these get infected. And through them, when the people are handling them, it could be either the sick pigs being handled or the abattoir workers or some veterinarians or whoever. So these people, when they handle it, they are at a higher risk. So animal to human can happen. And as already mentioned that in Malaysia, pigs were very much involved. And human to human also happens, as I said, in Bangladesh and India. And especially this happens with close contact people who are in close contact. And once they are in close contact, there will be respiratory secretions, excretions. So all this get, in close contact. This forms a chain where this will be infecting the people who are in close contact. And health workers, he's already mentioned, they are at higher risk because this disease spreads fast and also has a very high degree of fatality. So what happens is, if at all there is not adequate protection or while nursing care, the health workers don't take adequate protections and barrier methods and all. So then this gets, even a nosocomial infection is seen. So these are some of the things. So I think the simple things sometimes which can prevent is even hand washing or using sanitary measures. All these are very, very important when it comes to this. So these are some of the ways that you can see that Nipah gets spread.
Yes. Thank you, sir, for the excellent answer. One thing I want to add here is that in Malaysia, the farmers have the habit of putting water pots at the palm trees. And they keep the water pots there overnight. And then in the morning, there is some ritual. So in the morning, they take the water pots and drink from those pots. And what happens that bats come there and the droplings are there and the pots get infected. And with that, the spread of infection is there. So there was this habit also mentioned, and because of which the Nipah was spreading, and they have totally controlled over it. Now they have educated the farmers, and no more they are doing the same. Okay, next we move on to Dr. Vishnu Chaitanya. I have a very interesting question for you, Dr. Vishnu. Pigs have always been there. Bats have always been there. There have been huge pig farms in Malaysia all throughout. Then why now? Are we inviting the viruses to us, or are we going into their territory? Why now this kind of virus infections?
There are three important reasons for that, ma'am. The first one is deforestation. Studies on Pteropus bat roost ecology show that these bats prefer fragmented forest landscapes. As deforestation is happening on a wide scale, the fruit bats are coming into human areas for food. And these bats are fond of fruits like bananas, guava, mangoes, etc. And the bat-bitten dropped fruits are hand-picked by the farmers and are fed to the livestock. And this is how the disease transmission occurs. And the second important reason is human behavior. It is a customary practice in India to cultivate date palm sap. And these bats are never equipped to strip the bark off trees to get the sap. The sap is a human provided food resource that these bats learn to exploit, particularly in winter where food shortage occurs. And one more behavior is bat hunting, which is common in eastern Ghats of India. Bat meat is consumed for certain unproven medicinal purposes or as a part of rituals. So these are the main reasons despite long-standing bat and farming ecosystems.
Basically, we are inviting them into our territory, and that's why we are only suffering. Even the pig farms have increased in numbers so far. Like now, there are like pigs of a number of around 50,000 in farm, and which is quite a huge number. So because of this, we are seeing more and more problems with the ecosystem. So these were the basic questions about history, epidemiology, virology. Now let's move on to a more clinical part of this. So I would ask Dr. Gagan Gunjan sir, person to come in contact with the patient, like first contact person with the patient. So how do we suspect that this patient, it is already mentioned in the presentation, but still, how do we suspect that this patient could have been Nipah virus infection? What should be the 1, 2, 3 numbers that we know that this patient could have Nipah, and then we isolate the patient and send the samples? Sir, you are on mute.
Actually, the first person to come in contact or getting infected with the Nipah virus is most probably and high probably the healthcare workers or healthcare givers who are in close contact with the patient, because they are at high risk of getting infected with their body fluids like nasal or respiratory droplets or urine or blood or saliva, because they are coming in contact with that person. So they are at very high risk zone of getting contaminated with the Nipah virus. Now, if we come to the suspicion part, then there is clinical features. Then if we look, then it can be mild to severe, something, anything. Because if we look at the symptoms that typically appear in 4 to 14 days following exposure to the virus, the illness usually presents as 3 to 14 days of fever and headache, and often includes signs of respiratory illness as the disease progresses further. So to start with initial symptoms, if you have any of these like fever, headache, cough, sore throat, difficulty in breathing or vomiting, then you need to suspect that patient in the clinical scenario and in the context of Nipah virus infection. These are the initial symptoms that you should look for. And if you move forward to the severe symptoms, then it could be either in the form of disorientation. Then we have drowsiness, confusion, seizures, coma, brainstem symptoms that already was discussed earlier, and then features of encephalitis. So coming to that part, you should be very careful, like fever with altered sensorium, fever with drowsiness or disorientation or mental confusion, which can rapidly progress to coma within 24 to 48 hours. So you have to be very cautious regarding the initial symptoms in context to Nipah virus if you have any high grade of suspicion for that.
Absolutely, sir. So basically, in epidemiologically significant area, if the patient is coming with fever, with signs and symptoms suggestive of encephalitis, with ARDS, then we must suspect Nipah in those patients, especially when there are cluster of cases noticed in recent times. Very well put, sir. And now we move on to Dr. Uma Maheshwari ma'am. Ma'am, if the patient is suspected to have Nipah virus infection, what samples should we send? What all samples can be sent, and what all testings can be done, like RT-PCR, NAT, NG sequencing? What should we do, and what samples should we send? And practically speaking, where can we send these samples? How many laboratories are there in India where we can send?
Basically, the samples can be oral, nasopharyngeal swab, throat swab, sputum, blood, that is serum, then CSF sample. These are the basic samples. There are direct methods and indirect methods for testing. Direct methods, directly virus isolation, and RT-PCR, the treatment of diagnostic test at present. And there are other immunofluorescent assays also, and immunohistochemistry also, but RT-PCR is the test at present, the test of choice. And other indirect methods would be serological tests, virus neutralization tests also are there. In the serological test, ELISA is the basic test which we are doing. It can be IgG or IgM, sandwich indirect and direct ELISAs. So at present, NIV Pune is only our Apex lab. Anything is there, confirmatory diagnosis is through NIV Pune only, culture. So when it comes to any outbreaks, are there in our particular states or anything, then it is our responsibility to inform the NIV Pune only. So they are the persons who are primarily responsible. So they will again, or any state health, after that we should also inform the state health authority, district health authority also. So NIV Pune only will instruct these state health authorities to initialize point of care testing or ELISA or PCR in that particular area, in that particular state. It can also assign the virus VRDL test centers in that particular state. No private lab has any role here. No private labs can take the samples or transport the samples on their own. It is everything government only. They have to notify to the government. Government only will allot the personnel, trained personnel to collect the sample and also to transport the sample. So that is the protocol. So it is finally NIV, ICMR only, which is the Apex lab for us. So that is the protocol.
How long does it take? Like if I am suspecting a patient in West Bengal and it goes to NIV Pune and then the report comes, approximately how much time does it take?
That depending upon the transport which we choose, it can be air or through ground transportation also, following the choice which we are. But prior information should be given to NIV Pune before we are testing. Right. We are planning to do. Prior information should be given to them that we are sending the sample to them. So they will tell us what we should follow and all. Everything they will only guide us.
Because in these patients, in West Bengal case, the sample was sent first to AIIMS Kalyani, and there it came positive, and then it was sent to this Pune Institute. I think that is the how they would.
Yeah. But finally, Apex Lab is the one which will take a decision.
So final decision will be from the Pune.
Yes. Yeah.
Okay. So Dr. Venkat, Ramesh, I have two questions for you back to back. First is, we have seen that we have sent the RT-PCR. RT-PCR is now positive. So now this is the most important part, that how do we treat these patients? Practically speaking, what medicines are available and how do we give?
Right.
And then I'll come back to next question.
Yeah. So in terms of treatment, actually, the mainstay of treatment is supportive, whether it is a mild case or even a severe case, right? So now we look at the three clinical presentations, and I'll just tell you a couple of points about the supportive management. So let's start with acute encephalitis. You need to keep the patient at 30 degrees elevation. For seizures, you need to give whatever fosphenytoin, phenytoin, levetiracetam, and mannitol can be given. So that's the symptomatic treatment part for acute encephalitis syndrome. For ARDS, I think I'll be preaching to the choir because all of you are pulmonologists, you are experts in management of ARDS. But just to reiterate, so low tidal volume ventilation, high PEEP, and maneuvers. I mean, I'm not the expert, but I think ARDS management, chest physicians are the best. Third thing is for myocarditis, yes, you will use dobutamine and dopamine. And if patient is in heart failure, those particular measures will be administered. So mainly supportive. Then, if you look at the Kerala protocol, they mention about monoclonal antibodies. I think it is something like 102.4 and it's 20 mg per kg given twice over 48 hours. Um, Again, they don't mention specifically which patient should not receive it, but if you see the flowchart, it does go through that. And then, in order of importance, the antivirals, remdesivir first. If remdesivir is not available, then favipiravir, and if both are not available, then you give ribavirin. So it says, if you look at the flowchart, it says or. So I mean, perhaps these patients in
Yes.
care in West Bengal, they received more than one antiviral, but I think as per the Kerala protocol, the first medicine is, I mean, the recommended antiviral is remdesivir.
Remdesivir.
So
Yes.
I think that's monoclonal antibody and remdesivir are recommended. And if remdesivir is not available, we go for favipiravir. And if both aren't available, then ribavirin. So that's, but mainly again, it has to be good critical care management. I think that is the take home message. Good critical care management, manage the patient with encephalitis, ARDS, and myocarditis well. And I think that is 90% of the job.
So remdesivir is easily available. We can recruit it easily.
No, it's
Remdesivir.
No, it's not. So I mean, we try to get it for a patient. I mean, not me, but some patient in Mysore. And I tried to contact some distributors here because a friend of mine needed it, and I was just not able to find it. So I think they have stopped
Yes.
manufacturing it. I may be wrong. So
So
it's
in
not
these
very.
patients of West Bengal, they could get them
Yes.
remdesivir, but that was after 3 days.
Yes.
So initially they started with other antivirals. So all three antivirals were given to them. Maybe because the remdesivir was available only after 3 days of finding out that those patients were RT-PCR positive.
Right.
So you think that remdesivir antivirals work there or supportive treatment? What do you think?
So generally, the principle for any viral infection, the antivirals need to be used in the first 5 days. That is the general principle. And if you look at even our COVID study, antivirals in general will not have a mortality benefit. Even if you look at influenza, right? You look at oseltamivir and for hospitalized patients with influenza, there is no evidence that oseltamivir improves outcomes. Yet we give it day in and day out. So the data
Yes.
for antivirals in a mostly immune-mediated phenomena is perhaps limited.
And what is the role of steroids? That is my second question. Immunomodulators you already
Right.
mentioned. And what about steroids?
Yeah. So steroids, see, there are some definite indications for steroids. If patient has a classical HLH-like picture or a cytokine storm, GCS of less than 8, a rapidly progressive neurological deterioration, steroids are indicated. Now, whether to give steroids in a patient with isolated ARDS without any of these, that is, I mean, it's not mentioned in the protocol as such, but I think there is overall all the data that we have suggests that steroids may have a benefit in patients with acute respiratory distress syndrome, irrespective of etiology. And if you look at again recovery trials in COVID, in viral pneumonias, when it goes into the severe or critical phase and patient is dependent on oxygen, you can use something like dexamethasone, maybe 8 milligrams once a day.
0.5 milligram per
Yeah.
kilogram dose maybe.
Or prednisone, yes, prednisone can also be used. I think that on a case by case basis, it can be taken. But for acute encephalitis, definitely GCS of less than 8, rapid progression, HLH, cytokine storm, you need to use. And
Steroids.
again, I think I would again caution against use of, let's say, treatments such as tocilizumab, which have been used in COVID. You just cannot apply them in something like Nipah. Because steroids, at least we know what we are dealing with, so that seems to be a bit more reasonable.
Just out of curiosity, I want to ask one more question: that what antibiotics would be using here, or would you not be using anything Patients are usually intubated on ventilators. There is no indication of antibiotic as such, but we are giving steroids. They are on ventilators. So what prophylactic antibiotic will you give to these patients?
I mean, yeah, difficult to deny the patient who's critically ill antibiotics, but post-viral pneumonias are typically you need to cover MRSA and
Yes.
pneumococcus, group A strep. So you need a good gram-positive coverage, and because I mean, personal belief in India, we see a lot of gram negatives. So give a broad spectrum antibiotics, such as perhaps cefoperazone sulbactam, with a good gram-positive cover for MRSA, whether that's vancomycin or
Linezolid or something.
teicoplanin or linezolid is of course another question, but yeah, you would do that in patients towards the more severe end of the spectrum rather than in the mild or moderate cases.
Yes. So once the severity is increased, we can't deny antibiotics, as you
Yes,
rightly
of
said.
course, yes, yeah, and I
Okay.
mean it's such a high case fatality rate of 40 to 75%. You should err on the side of giving antibiotics rather than not in a critically ill patient, no doubt about it.
Okay. Thank you so much for the
Okay.
perfect answer. So next we move on to Dr. Vishnu. Dr. Vishnu, one of the challenges with Nipah virus infection is rapidly clinical deterioration. So what are the some clinical laboratory or physiological markers that should alert clinicians, pulmonologists, and critical care specialists like us that this patient is likely to become critically ill and it requires ICU escalation?
Coming to the clinical markers, we need to look into the neurological manifestations. Something like altered mental status, that is disoriented to time, place, or person, drowsiness, confusion, seizures, or coma onset within 24 to 48 hours of encephalitis symptoms that demand urgent transfer to the ICU. Not only that, segmental myoclonus, hypotonia, areflexia, gaze palsy, limb weakness, and all these things are also heading towards the ICU stay. So coming to the next one, that is the respiratory manifestations, labored breathing or hypoxia because of pneumonia leads to hospitalization, especially when we deal with the Bangladesh strain, because there is more lung tropism to the Bangladesh strain. And coming to the cardiac manifestations, it include tachycardia, hypertension. This can also warrant ICU stay. This can occur because of viral myocarditis or due to stress-induced cardiomyopathy. And coming to the laboratory markers, thrombocytopenia, elevated SGOT, SGPT levels, and increased levels of serum lactates predict poor prognosis and severe disease.
Do we look at ProCal, CRP, or any other markers in them?
In case of secondary bacterial infections, these values,
Yes.
the serum procalcitonin levels will be raised. But otherwise,
No. Right. Okay. And one more question to you, Dr. Vishnu, that it is regarding you are the only pulmonologist other than me in the panel. That's why this question goes to you. That how different is this ARDS from what we see otherwise, other viral ARDS, especially COVID? So how different the presentation, or how do you know that this is Nipah ARDS? And plus, how do you manage?
Yeah, there are certain important differences between Nipah ARDS and COVID-19 ARDS. In case of Nipah ARDS, the primary target is endothelium, whereas in case of COVID-19, both alveolar epithelium and endothelium are involved. And the nature
Okay.
of injury in case of Nipah ARDS is vasculitis and capillary leak. Whereas in case of COVID-19, it is diffuse alveolar damage plus microthrombosis. And the thrombotic tendency is more in case of COVID-19 when compared to Nipah ARDS. And coming to the time course, there is rapid and fulminant course in case of Nipah ARDS when compared to COVID-19, which is often gradual. And the multi-organ involvement is more noticed in case of Nipah ARDS when compared to COVID-19. And the treatment remains same for any ARDS. We must follow ARDS net protocol, that is low tidal volume ventilation, that is 4 to 6 ml per kg predicted body weight. The PPLAT should be less than 30 centimeters of water, PEEP titration, prone positioning ventilation, and neuromuscular blockade is to be given in case of moderate to severe cases. That means whose PF ratio is less than 150. And one important thing regarding non-invasive ventilation, these patients will have usually concomitant this encephalitis plus ARDS, and these patients are usually drowsy, and there is a risk of aspiration. So non-invasive ventilation is contraindicated, and we must escalate to early intubation with airborne precautions. If the hypoxemia is refractory, then we have to go for ECMO. And along with that, already Venkat Ramesh sir has already told something about antivirals. The antiviral choice is remdesivir. If it is not available, then favipiravir, then followed by ribavirin, and usage of monoclonal antibody M102.4, and seizure control, and also the intracranial pressure monitoring, and all these things also play a significant role in the management of Nipah ARDS.
Excellent. And what about tracheostomy? Would you go for early tracheostomy in these patients?
Yes, ma'am. It is like any other ARDS protocol. If the patient is being intubated for more than 7 days, then we can go for tracheostomy.
Tracheostomy. Okay, excellent. So we have covered most of the part of the clinical features and diagnosis. Now let's move on to the infection control prevention part, which is, according to me, the most important part of the entire session. So to Dr. Animesh Jain, sir, so once the Nipah virus is confirmed, how is contact tracing carried out? What isolation and monitoring are required for the contacts? And do we give them prophylactic antivirals?
Thank you for the question. And again, I would also like to place a disclaimer, like my co-panelist did that during his presentation. So, see, I have not personally seen or managed a case of Nipah, but I am very close to the Kerala border, let me tell you. Okay, the Kerala border is hardly 35-40 minutes from here. And I've had very good friends who have seen, and then I have been able to interact and learn from them. So first thing first, see, we talked about contact. So now let's understand what is a close contact. So close contact is basically a person who's actually had exposure towards a person who was infected. It could be a person who was a suspect case or a confirmed case, and this person happens to share a ward or a room with this person, or direct contact during the transportation or during the illness itself, or sometimes the person has passed away and the funeral rites time, this person had a direct close contact. Now, this could also mean that any exposure to blood or body fluids as well. It could even be sometimes the person was wearing some clothes and all, and these were handled because Nipah is highly contagious in that way. But what I want you to understand is, especially here, is that again, the risk is to be stratified. Now, based on this, what I said, yes, they are close contact. But then this is again stratified into high risk and low risk. Now, who's a high risk? So, who's had a direct contact with the body fluids of a confirmed case, or had a more than 12 hours period in a very close proximity or in a closed space, or probably a person who was suspected to have Nipah, but then we could not prove it by a lab confirmation, and the person happened to pass away, and the person had a contact with someone. So these are the people who would be considered as a high risk contact. Other than that, just touching clothes and linens and other things, or anybody who's had less than 12 hours of contact, they can be classified as low risk. Having said this, now usually what we do is we look back into 21 days, that is 3 weeks period for a contact. And it's very important here, the principle of contact tracing is followed. So when we find out the people who have been into one of these stratification of the risk, what we need to do is people who are high risk and they are asymptomatic. So they are advised to quarantine at home itself. And what a health worker does In fact, again, I'm deriving many of the things even from the Kerala guidelines which have come, which was mentioned in the presentation. So what is done is a health worker will make calls. So twice a day, they make a call to follow up, finding out their health condition. A person who's symptomatic is usually advised immediate isolation with, even if required, ICU facilities. And when it comes to people who are with low risk, who are asymptomatic, so they are home quarantined and again just telephonic follow up for fever. But if they are symptomatic, even though they are low risk, then they have to be admitted. And that is what is usually required. And what do we document? So we document the person's name, age, gender, address, phone number, when was the last contact done, and who are the other people probably might have been exposed, what was the exposure mode. So all that is actually looked into. And this is again in primary care, like which happens at the primary grassroots levels. The health supervisors or inspectors will be collecting these details from either the staff nurse or any hospital responsible people, and then they will go and figure it out, and then contact tracing will be started. And these are all to be reported to different authorities, including the district health system, district medical officer, district health officer, the IDSP, that is Integrated Disease Surveillance Program, and this will be promptly noted and reported. So this has to be followed very strictly, because Nipah is a serious disease, and it has a lot of fatality which happens.
And what about RT-PCR, sir? We do RT-PCR of symptomatic contacts or asymptomatic contacts, or we don't do at all?
As per the guidelines that I went through, I don't think I came across that. It's not that they have advised that, but any of my co-panelists, if they have something, they can probably add. But to my knowledge, and from the guidelines, as I said, I've not directly managed, but this is what is till like we are looking into this. So we are just looking at monitoring them, and we don't directly do the RT-PCR for contact directly immediately, as I understand.
Okay.
This is what I understand.
Yes. Maybe if they get symptomatic, they are tested with RT-PCR, but asymptomatic.
Then, yeah, if they are symptomatic, yes, then we will have to, because then we will have to follow up the protocol to even figure it out, and then even rule out the differential diagnosis. So that, yes.
Okay. And what about prophylactic antivirals?
Not that I know of. They don't have prophylactic, don't have any role. In the treatment, they are advised, but as such, for the prophylactic part, they are not really having any role.
Okay.
But treatment-wise,
okay.
Yes, treatment, we do use any of these. Basically, the most important thing that we need to remember is we have to find out the contacts, we have to stratify it, and we need to follow them up so that they are able to be traced. And anytime like they are going to be deteriorating, we just get them and treat them promptly. That is what is the important thing here.
And actually, it is a very difficult task, as we know that this West Bengal case, the female nurse, had been to many places during this 4 to 21 days period. So she had gone to Bangladesh border for some wedding, then she went to her hometown, then she went for multiple doctors also. So it was so difficult for them to trace her contacts. It became really a tough job. Okay, sir, again, next question.
No, same thing even in the previous Kerala outbreak also. It was quite, because that person had gone to multiple, that young person was there, and he had gone to multiple places, and it was really so one of my close friends in community medicine from Calicut Medical College had taken a very active part. So I had heard the first hand the experience. So it was very difficult, but yes, they had to. And one good thing is, in Kerala, somehow we have a very good system of this active surveillance. Anything and everything, they have a very good system, and that's why one of the reasons, probably that one of the reasons why most of the diseases first come into picture from Kerala.
Yes. Okay. And next question is again to you, sir, that this is about contact tracing. But what about healthcare workers? This again and again we are coming to same question, but this is very important. That's why we are repeating the thing that once the patient is admitted, patient may be admitted with fever and encephalitis. That time we don't know that it is the case of Nipah. It must be in contact with so many healthcare workers, and then the RT-PCR comes positive. Then what is the strategy here?
So first thing is like see high index of suspicion and doubt. And as it is said, like, universal precaution, something like that, I would say that it's a better idea that healthcare workers take precautions, and especially when we have any needle of suspicion and that there may be an outbreak, or there may be a case coming up. So then definitely it's good idea to use the personal protective equipment. It could be using N95, the face shield, the goggles, gloves. All these are important. And very importantly, the patient has to be isolated. Preferably, the patient should be isolated so that it doesn't lead to more people getting infected. And other than that, even if we have to do some procedures and if can generate probably aerosols, it should be avoided only if it is necessary. And in that case also, precaution should be taken. As far as possible, close suction should be used, and minimal number of people, not just for procedure, for other things also. As far as possible, don't expose too many people, too many healthcare workers and staff for these kind of people who may be suspected till we get a confirmation. And the other thing is, it also is important that we train even the other paramedical and ancillary staff to handle these linens, the equipments, the biomedical waste, how to dispose them and properly and keep themselves protected, because they can also be exposed. And from them, again, the healthcare workers are at risk. And very importantly, it's a good idea to monitor the staff for their, like if they develop any kind of a symptom. So keep that also in mind. And they should also be voluntarily encouraged to voluntarily report these things. And if at all anybody develops symptoms, they should immediately be promptly isolated, tested, and then immediate measures should be started for them as well. So these are some of the simple things which can be tried. I know it's not as easy, but one of the things is high index of suspicion, using the personal protective equipments and taking care that trying to expose less number of people and keeping everybody aware and educated about how to handle these things.
Yes, very well put, sir. So basically, we should be wearing mask and personal protective equipments now and then. So it should not be like we are just walking in the OPD without mask and we come across tomorrow with some unknown bug and then we blame them. So basically, it should be protected always. And as per the guidelines they are mentioning, even the 3-layer mask is enough. We don't even need N95 for this. 3-layer mask, we don't need the full PPE for Nipah, but this is also enough when we are suspecting the patients. We don't know the patients are there yet, but when we are suspecting the outbreak, even this much is enough.
Dr.
Okay.
Venkat wants to add, I think,
Yeah,
something.
no,
He's
sir, I
raised his
just
hand.
wanted to, I am not sure, sir, about the close contacts, whether they are tested or not, because I'm just asking. In this current outbreak, as per WHO, it's clearly there on the WHO website that the 190 contacts were tested.
Were tested,
So,
yes.
yeah, but even when I looked at the Kerala document, I don't specifically remember
Yes.
about they have not clearly mentioned about asymptomatic contacts being tested. Of course, symptomatic they have to be tested.
Yes.
I'm not sure, sir. That's what.
No, even I went through the Kerala. That's one of the most comprehensive guidelines which have come in, and that's a very good document, in fact. And I also went through that, and I didn't find that asymptomatic have been tested.
Yes. I think in West Bengal, perhaps they took a more proactive approach. That is my guess. Yes.
So, and this time they had provided the mobile laboratories also there
Yes.
because the lab testing was more. So this time all these precautions have been taken. Okay. So the next question is to Dr. Gagan Gunjan, sir. Sir, how important? We all have heard about One Health approach. First, help me understand what is One Health approach and how it is important in preventing Nipah virus outbreaks, and a lot more about it. So you are on mute.
Actually, One Health approach basically refers to multidisciplinary approach. And we all are aware that working in a team can give a good control to anything. So multidisciplinary approach here, we need to involve specialists from both medical fields and veterinary fields. Because we have already seen fruit foxes, how they can spread and how humans can, from one human to other human, it can spread. What we did in COVID was isolation, tracing, and testing. The same applies here also to break that chain. If we have failed to break that chain, then it will go on to continue from one person to other person. If we are able to break this chain, then we can definitely curtail the infectious rate also and mortality rate also. So basically, we need to to involve all the fields, so that is medical and veterinary fields. Then we have ecologists, then we have virologists, microbiologists, infectious disease specialists, all coming together and working under one umbrella. That is what it means, One Health approach. And definitely, this is the only way of curtailing it from spreading further. So this is very important for us, and we need to work on this.
Okay. Thank you, sir, for the elaborative answer. Now, the next question is for Dr. Uma, ma'am. Where do we currently stand with regards to Nipah virus vaccine? When we are talking about infection control and prevention, vaccines are going to be there. So where do we stand here? Do we have any vaccine in the pipeline or available? And if at all, what are the high-risk groups which need to be vaccinated?
As far as vaccines are concerned, as for February 2026, no vaccine is available commercially for human use. That is what,
Okay.
as for February 2026. But having said that, Nipah virus vaccine research has tremendously progressed from preclinical studies to human clinical trials. So there are many vaccines which are at present in phase 1 clinical trials. Some of them are entering into phase 2 clinical trials. Phase 3 clinical trials are very difficult because of the virus, because of its sporadic nature and its unpredictable outbreak. So because of that, phase 3 clinical trials are really very difficult. Having said that, there are a couple of vaccines like ChAdOx 1 Nipah B. This is developed by Oxford University and Serum Institute, Pune. This one has completed successfully world's first phase 1 trial. It has completed and it has entered into phase 2 clinical trials in December 2025, Bangladesh. So this is the one promising vaccine. And other vaccines will be mRNA vaccine is also there, which promises 100% results in animal studies, mRNA vaccine. And Oro vaccine is also available, which is in phase 1 clinical trial at present. And there is other public health vaccine also, live attenuated vaccine. It is also in phase 1 clinical trial. And there is other monoclonal antibody also, where vaccine facilities are not available. Monoclonal antibody treatment for post-exposure prophylaxis that can also be used. That is also in phase 1 clinical trials. So apart from this, high-risk groups, definitely all healthcare personnel who come in contact with cases, all laboratory personnel handling the specimens, and people living in the endemic areas mostly, and people who are livestock handlers, agricultural farmers, all these people are at risk. So these are the main high-risk groups would be these.
Thank you, sir. Thank you, ma'am, for the insight. And I've heard that these vaccines, which are in phase 3 trials, they are going to be protective even against other RNA viruses. They're not just Nipah specific, but they'll be giving against, 2 or 3 more viruses. Okay, so we are done with the infection control part, and now we are moving to the final phase of our discussion, and that is outbreak management, which is the current favorite thing. So, Dr. Animesh, sir, there were 2 cases in West Bengal. So do we call it as outbreak? What is classified as outbreak? And I want to know the formal definitions of things like primary, secondary, subsequent cases.
So very good question. See, in case of things like Nipah, it's not that you have to have some few number of cases or something. In fact, in this context, like I to give you a kind of parallel, maybe. See, if we get one case of maybe say cholera or something, and especially in a developed country, that's an outbreak. So similarly, even one case, single confirmed case of Nipah will be considered as an outbreak, and it should immediately warrant containment measures. In fact, if you see 2018, we had only one index patient followed by the spread. 2019, similarly, we had one confirmed case, and a lot of activities were launched to contain it, control it, and that helped actually. So this is what is the idea, that even if we get one single case, that should trigger, and then all the kinds of things should be started. Now coming to the suspect case, see, the symptom complex is there, especially if a person comes from an area which is affected, and that person shows any symptoms like what Dr. Venkat also had mentioned, acute fever or mental sensorium and alteration, seizures, or maybe a headache, with or without cough or shortness of breath. So this should be taken as a suspect case. But what is considered as a probable case in this, as I mentioned some time back also, that we thought that this was a suspect, and we wanted to probably collect a sample and want to figure out that whether there was a actual confirmation or not, and this person passes away. So then it could be a probable case. That could also be one of the things. But the moment we get a confirmation, a lab confirmation, whether by PCR, through the throat swab, or urine, or serum. So this is known as a person who was suspected now has become a confirmed, because we've got a lab confirmation. Now, the index patient is the first patient who's been identified. So that is the first. But anybody who's after that, who's probably a result of human to human transmission, that will be considered as a secondary case. So the index would be the first patient who's identified by the health system. And usually this person would have had a like infection via the zoonotic route. Whereas the person, now suppose it's a XYZ person who's been infected, and from there we got to know that contact tracing and other people. So the others who are there are the secondary cases. So this is how we go about when it comes to defining these cases.
Very nicely put, sir. This clears all the doubts about outbreak and definitions of the cases. I'll come again to Dr. Uma, ma'am, that during the outbreak, we have more or less discussed this question, but during the outbreak, large-scale testing becomes essential. So, could you explain the role of this is biosafety level 3 or 4 lab? And what is the role of these labs, the mobile labs that are available now? And do we have adequate capacity of this if we have a huge outbreak of Nipah in India? And how the samples should be transported to these laboratories?
Yes. Biosafety level 3 labs, they are critical in handling Nipah virus. So we have biosafety level 3 in India. Under ICMR only we have 10, 2 being that mobile biosafety level 3 labs, and others are covered under CSIR, DBT, something like that. Other totally 23 biosafety level 3 labs are there. See, biosafety level 3, it provides containment and negative pressure rooms are there. So the virus is free, it doesn't escape, and it provides double door autoclaves are there. Freezers are available for safe storage of the samples, and whatever the biological waste is there, the decontamination facility is available, and PPE is available, respirators are available. So it not only offers protection to the laboratory personnel, but the sample which is there, that is also safe, environmental safe. So after that, HEPA filters are also available in that. And what was the other thing which you have said? Biosafety level 3. Sample transportation. Sample
Yes.
transportation definitely in the triple packaging system, and cold chain maintenance has to be there. If it is less than 48 hours duration, it has to be under 2 to 8 degrees centigrade. It has to be sent. If it is more than 48 hours, something like dry ice packs, you have to put them and transfer in cold chain only. And in that triple packaging also, there has to be special mention. I think all of you are aware of the triple packaging. We had done so much in COVID this thing. Apart from that, we have to follow certain guidelines of IATA and the Dangerous Goods Act also is there. That also following all those that. And special mention of the consignee and consignor's names have to be there. And orientation arrows have to be placed on that. And we are not supposed to use any glass containers for the transportation. And always that UN number has to be mentioned. If you are using special gel packs or ice, that product will have that special UN number. So you have to mention that UN number also on that carton. And apart from that, packaging instruction, you have to give that UN number and PI 620, something like that. If it is containing any dangerous item, infectious category, that also you have to mention. So these are the precautions which you have to follow.
Yeah, very nicely explained, ma'am, step by step. And it is also very nicely given in this Kerala guidelines that how do we make the packing and how do we send the samples. Okay, so Dr. Venkat, Ramesh, the next question is for you, that why it is classified as priority pathogen by WHO, and why it is listed as class category C agent. What is the meaning and why it is listed like that?
So there are two different things actually. World Health Organization had come up with research and development blueprint for what they've labeled priority pathogens. So priority pathogens, because they have a high case fatality rate, zoonotic transmission, limited data on antivirals, treatment, diagnostics, mode of transmission, and because see, whenever you have a case, you need to do the research in that time. You cannot predict what will happen unless you have the case in front of you. So that is why you have a research and development there, so that you can act as soon as the case is there. Number one. Number two, for the CDC, actually, they have category A, B, and C in terms of bioterrorism threat. So category A would be something like botulism or anthrax. Category C is like less likely, but if it does get into the wrong hands, yes, there is a threat for bioterrorism potential. So that's why these two different classifications. So WHO is talking more about how you require enhanced diagnostics, enhanced treatment, maybe more and more in vitro studies, so that when the outbreak is there, you're able to act immediately, even vaccination, all those things. There's no available vaccine. And the CDC classification is more of a bioterrorism risk. So in terms of that, it is a little lower. Category A and B are higher. So yeah, but there is a risk. It is not like there is no risk. There is a risk, but it is lower.
Okay. And priority maybe because of the high mortality.
Mainly because of, it is very limited data. Yes, very limited data, high mortality, and no recognized like prevention strategies or antivirals, no vaccination.
Yes. So that's why the priority pathogen.
Yes.
Very well put. Now for Dr. Vishnu, I have a very practical question. So based on public risk assessment published by WHO, how much risk do we have sitting in different parts of India? Are we at the risk? Can we travel? Can we travel to these areas which are epidemic for Nipah virus? This is a very practically asked question. So what do you think about it?
World Health Organization currently assesses global and regional public health risk from Nipah virus as low. But 24 Parganas district of West Bengal is considered as moderate risk. And World Health Organization doesn't recommend restricting travel or trade-based on the current situation, and several countries in Asia have enhanced airport health screening and surveillance. And there are certain general advisories to the travelers who go to the other countries or other places in India. They must avoid contact with bats and sick animals, avoiding consuming raw date palm sap or partially eaten or contaminated fruit, practicing good hand hygiene, and seek medical attention promptly if you have any symptoms and signs of Nipah virus.
Yeah, so excellent. So we should not be worried too much, but we should be definitely be careful, right?
Yes, ma'am. Correct.
Okay. Okay. So my last question to Dr. Gagan Gunjan, sir. I started with you. I am ending the last question to you. So from a health system perspective, what gaps have Nipah outbreaks exposed in surveillance, hospital preparedness, and intersectoral coordination in past? Sir, again, you are on mute.
Just now we had the last like one health approach. That is the lack of coordination and everything that can. So we need to build a better coordination both at the national level and international level to trace out the cases for active case search. That is important, and restricting them from moving and restricting them from spreading by multidisciplinary approach. That has to be number one. Then we need to create health awareness and community awareness program. That's how we can educate people and we can ask them to contain and go for. That's what we did in COVID also. We asked the patient to go and get yourself tested. And that's how the things were turned out to be positive outcomes we had then upon. So we need to educate the patient. We need to have community awareness. We need to have take measures of prevention in high risk areas. Then we can grade the areas according to low risk areas we are talking about, and then high grade risk areas. And we can have simple protocols like washing of hands with soap and water after coming in contact with a sick person or animal or before leaving the cattle farms. That is important. Have a proper hand wash. Avoid consuming raw date palm sap. Consume only washed fruits. Avoid consuming half-eaten fruits from the ground. That is probably sir was talking about being eaten by bat or fruit bats and then getting infected from there. Avoid entering abandoned areas where bats have a inhabitat. Bats are the inhabitants like in abandoned areas like some deep caves or well. Handling of dead bodies should be taken care in confirmation with the government protocols that come from time to time. And then we have to try all the methods of reducing the risk to human transmission or animal to human transmission through these methods. And this will go in a long way, very positive outcome.
Thank you, sir. So there have been some gaps in the past, but so far I think we are doing very good when it comes to curtailing the Nipah virus.
We have learned a lot from COVID, and we have learned a lot from COVID, and we are simply just we have all those
experiences. Just applying the same
that's
principles.
That's why we have been able to curtail this time to a lesser extent.
Yes. I totally agree with you, sir, here. Okay, there are some questions in the chat box. Some we have answered, some we haven't. So, Dr. Sanjay Verma from Chandigarh is asking, what are the criteria for discharge? Can any one of you answer this? Dr. Venkat?
Yeah, I think I'll take this. So I think, okay, so two types of cases are there. I mean, one is for confirmed cases, they need to be asymptomatic, and RT-PCR is to be tested negative on 3 samples, blood, urine, and nasopharyngeal or oropharyngeal swab on 2 occasions at least 5 days apart. And
so total 6 samples we have to test, right? The 6 samples, 3 plus 3.
Yes. And again, the treating clinician will decide on the discharge, but it has to be approved by medical board. Okay. So that's about the symptomatic cases. I mean, the confirmed cases. Then the high risk contacts who are in the designated facility, if they initially tested negative, let's say they are symptomatic, they initially tested negative, then you repeat the test, and they need to be asymptomatic, and 2 negative tests have to be there before we discharge the high risk contacts. So that part needs to be there. And there is a follow-up also. I think, they, I mean, even if they get discharged, they need to be at home for 4 weeks, these confirmed cases, and they need to follow up at 28 days, 56 days, and 90 days, because sometimes you can have a relapsing encephalitis.
Yes.
So that has been reported.
So follow-up is basically for encephalitis mainly.
Yes.
Yeah. What is the recommended duration of isolation in these patients?
Yeah, so the same thing as I mentioned, symptomatic cases, they need to be symptomatic confirmed cases. They need to be asymptomatic. 5 days apart, you need to, so total six samples you need to test, and 5 days apart. So only then they can be discharged. And so see, when you test the close contacts, not everybody will be, not everyone will have Nipah. Obviously, some will be symptomatic for other reasons. So if they are symptomatic, you do the initial Nipah test, it comes negative. Still, you need to keep them test after 48 hours. If that is negative, their symptoms have subsided, only then they can be discharged. So basically, you cannot discharge if the patient has symptoms, and you need to have two negative tests, whether it is symptomatic or asymptomatic. You need to have two negative tests. The duration of those two negative tests differs. So if it is symptomatic, 5 days, asymptomatic, maybe 48 hours. I mean, proven case, 5 days, doubtful case,
Symptomatic
wait for
means
48.
down.
Yes.
Symptomatic but doubtful, then it is less. Okay.
Little bit like COVID only.
Keeping the incubation period in mind, that is 4 to 14 days, we can have all those symptomatic and asymptomatic period, and we can think on that.
Yes.
This is as per the guidelines that he's mentioning.
Yeah.
But
Yeah.
okay. Yeah. So there are many more questions, but I think we have covered almost everything here. So one last rapid fire question for all of you.
So before that, I think somebody, Dr. Komal, somebody asked that how many days. I think I forgot to mention that. How many days of isolation? So generally it is 21 days. Yeah,
Yes.
21 days of isolation.
Yes, 21 days of isolation. Okay. So one last rapid fire question for all of you.
Rather,
One line
maybe
answer.
I would say quarantine rather than isolation. Yeah, quarantine. Yeah.
Okay. So one last question for all of you. That one lesson, if you want to take from this webinar, what would it be? We'll start with Gagan, Gunjan sir.
Proper hand washing after you are all done. That's the only preventive measure of any infectious disease. Have a proper hand wash. Change your clothes when you go home. That's all.
Okay. Dr. Animesh sir.
I don't know whether one, but I think first is maintain a high degree of suspicion, especially in such kind of situations, and go through mock drills, keep everybody aware in the health system, and make public aware about all these approaches, especially when it is like when we are experiencing these cases. So very briefly, that's what, because prevention is definitely better than cure, and we have to make sure that we take the public support in that.
Absolutely. Uma ma'am, what do you think about it?
Yeah, definitely, as sir said, hand hygiene and preparedness, emergency preparedness, that has to be there. The system itself has to be very, very strong to face the situation. And since I come from the lab, I would stress on continuous training has to be there, how to collect the sample. It's not like suddenly a patient has come, they get panicked, how to do. So that repeatedly, they have to practice how to collect the sample, and the packaging also, how to do the packaging, the mock drills, as sir has said. There has to be continuous drills, how they have to collect the sample, how the packaging has to be done. Then only when real-time event is there, they will be doing that without getting panicked in a proper way. So from my side, that would be the thing.
Okay. Dr. Venkat, would you like to say something?
Yeah. So I think a couple of things. One is, at least we should wear a triple ply mask, because that is the basic protection when we examine the patients in the emergency room. Those with suspected acute encephalitis or respiratory illness. Second would be that you need to keep this in mind even in 2027, 28, and going ahead. So, especially you see a patient with acute encephalitis with a ARDS, need to take a proper history. And for that matter, all patients with acute encephalitis syndrome need to take a proper history of travel and contact, because this can pop up anytime, right? So we just need to be aware of it. You're on mute,
You're
Doctor.
muted, Dr. Komal.
As you mentioned in your talk, first case should be the last case,
Yeah.
right? Okay. Dr. Vishnu, what do you think about it? What one lesson, if you want to take from this whole discussion?
Avoiding consuming contaminated fruits, proper hand hygiene, and pulmonologists should be aware of this acute encephalitis syndrome and combination with ARDS. We must think in lines of Nipah virus infection and get the medical attention promptly, get them treated with all the measures.
So basically, high level of suspicion and preparedness. All of you are saying that. But I would say that we should do more and more such webinars so that people get aware of it, and we also learn a lot from this kind of webinars. It was great to moderate this session. Even I learned a lot from all of you. Thank you.
Dr. Komal, please announce 1,712 logins, live logins. Dr. Krishna had messaged on the group.
Oh, that is amazing that we have a huge audience here. 1,700 logins are there. And I hope they got benefited. They got new information from our webinar, and we'll be better prepared for any such outbreak if happens in our area as well. Thank you. Goodbye.
Thank you.
Thank you.